Hello viewers, today we are in Bangalore in the campus of Shri Jaydeva Institute of Cardiovascular Sciences. Shri Jaydeva Institute of Cardiovascular Sciences in Bangalore is one of the largest heart centers in Bangalore, where daily on a routine basis around 200 interventional cardiology procedures are done, around 20 to 25 cardiac surgeries are done, and today we have with us Dr. Seetharam Bhat, who is the professor of cardiology in Shri Jaydeva Institute of Cardiovascular Sciences. So one thing about Seetharam Bhat sir is that he is the one who has pioneered heart transplantation program in Shri Jaydeva Institute of Cardiovascular Sciences. He is the one who has started and done the first cardiac transplant in Shri Jaydeva Institute of Cardiovascular Sciences. In 2018, he has been awarded by the state government Karnataka Rajyotsava Award, which is the second highest civilian award in the field of medical excellence. In 2018, he has been awarded. Today, we are going to discuss about cardiac transplantation. What are the various nuances of cardiac transplantation? Who are the patients who are going to benefit from cardiovascular science? We welcome you, sir.
Thank you.
Sir, kindly give a brief introduction about yourself. So, which place you hail from in Karnataka? And
Okay, I am from a village called Padebettu, which is in Padubidri in Udupi district.
Okay, coastal Karnataka.
Coastal Karnataka, now being famous because of the Kantara movie.
Okay, nowadays
People talk about it.
Yes.
I studied until 10th standard in the Kannada medium in a government school, and then PUC in English medium. Then I went to Ballari Medical College, did my MBBS,
Okay.
then my MS General Surgery from Bangalore Medical College. I did my MCH from Jaydeva Institute.
Jaydeva only.
And did some fellowship in USA in Portland, Oregon. Yeah.
Awesome.
And I have been working here from 1990 in the field of cardiac surgery for the past 32 years.
Okay, okay, sir. So, what exactly do we mean by heart transplantation? So, what are the various nuances we have to look? What are the patients?
Okay. Heart transplantation is a therapeutic procedure wherein a suitable donor's heart is put into a recipient's chest cavity after removing his diseased heart.
Okay.
So basically, because heart is a single organ, there cannot be a live donor.
Okay.
It has to be from a person who is otherwise not going to live, like a brain dead patient.
An indispensable organ.
Yes. So, and whose heart is functioning.
Yes.
So, it can be in the same hospital wherein the recipient is there and the donor is there. In one theatre, you take out the heart, in the other theatre, you put the recipient on a heart lung machine and then take the donor's heart and put it in the recipient's
Okay.
place of the heart. Or it can be from another hospital in the same city.
Okay.
Usually, once you take out the heart from a donor, you have about 4 hours, maximum 6 hours before you put it into the recipient's chest cavity and the heart starts beating.
Okay.
And that is called an ischemic time. It has to be less than 4
4
hours. Usually, the traffic is facilitated for the transportation of that heart from one hospital to another hospital by the local police. The police play a major role in transportation of a heart which has been stopped in another hospital and then it is brought to this hospital.
Clear all the ways and escort and all.
Yes, yes. And the heart comes like a big VIP from one hospital to another hospital. And when it is from a different city, sometimes helicopters are used or by aeroplane it is transported. The thing is, more the delay in transportation, more is the likelihood of a failure of the heart. So, less time is better, ideally less than 4 hours.
Okay.
Okay. So, the most of the hearts which come here from this city into Jaydeva is, we take about
like
2.5 hours.
The golden period is at the maximum 4 hours.
4 hours.
Okay, sir. So, how exactly is the heart transplantation done?
You take out the heart in the donor's chest cavity and put it in a preservative solution, put it in an ice box, transport it to the recipient's hospital, wherein By the time the heart is removed in that hospital, this patient, the recipient is wheeled inside the theater.
You got to have two surgical teams.
Yes.
Like
yes,
one who
yes,
is retrieving the organ and the other who is putting the organ.
Yes, yes. So that timing is very important, so that you cut short the ischemic time as far as possible for a successful outcome.
Okay.
And then you suture the various tissues, the inferior vena cava to inferior vena cava here, superior vena cava to superior vena cava, left atrium to left atrium, aorta to aorta, pulmonary artery to pulmonary artery.
Okay.
You do all this and then release the cross clamp, the heart starts beating. It's really, you know, something amazing when you see a heart that had stopped for 2 hours and was carried in an ice box and starts beating again. It is really a sight to watch.
To a common man, to a layman, it looks like a magic. It's like taking out a pulsating organ from someone which is giving life and just putting it in the chest cavity of other. So all the patients, what are the like category of patients which require heart transplantation?
Heart transplantation is basically, see, heart is a muscular pump. When it fails, when it is not able to put the blood in circulation, you know, all the organs start getting, you know, insulted without the nutrition, without the oxygen. The blood is the transport medium which takes all these things to different parts of the body and collects the impurities and, you know, gets excreted in the organs. For that blood to be circulating and going around the body, all the tissues, for their life process, the metabolism, heart is essential. So if the heart fails, it is not adequate, you know, adequate supply of blood to the different organs comes down, and the patient's heart needs some support, and you give all those supports, still it is not working, then the heart transplantation becomes the only solution. So it is an end stage heart failure and heart transplantation.
We can come to end stage heart disease, like where there is no option left.
No other options.
Like in intervention or medical management.
Yes, exactly.
So
it is a surgical procedure.
It is a surgical procedure and it carries its own risk.
Yes.
So briefly, some history about heart transplantation, where it was first done and who did it. Like
everybody knows Christian Bernard
from South Africa. But from the horse's mouth, we listen
it was done on, I think, December 3rd in 1967 in Cape Town in South Africa, and subsequently in 1 year about 102 heart transplants were done in about 50 centers in 17 countries in 1 year. But the result was not satisfactory.
Not promising.
The average survival was about 29 days in these 102 patients. And so in the 1970s, there was the heart transplantation disappeared from the clinical practice. Because it had a bad reputation. But in 1980s, it started a resurgence with the newer immunosuppressive drugs, the research in that field, and it restarted with and especially with the experience of the kidney transplantation. The heart transplantation made a resurgence.
Renewed interest
in the 1980s. In our country, the first heart transplant was done in All India Institute
AIMS
on I think August 3rd, 1994, and at present about more than 1,000 heart transplants have been done in our country.
In India only.
In India. And Karnataka in this year, I think they have done 30 heart transplants so far.
In Karnataka?
In Karnataka.
So that is remarkably a good number. So once we, because heart from the donor we retrieve, that is like a foreign body in the body of the recipient. So immune system is there, which has all the right to produce antibodies and cells to start the process what we call rejection. So how do you tackle rejection? And what are the types of rejection once you put the heart in the chest cavity?
Rejection is the biggest obstacle in any of the transplantation, because somebody else's organ is perceived as a foreign by our own body. So we have a strong immune system. We are in the middle of millions of organisms which try to attack us, and we we suppress it by our immune system. The same way, when somebody else's organ is put in our body, the body tries to reject it. It identifies it as not their own and rejects it straight away. So, so this early graft failure is by and large because of the ABO incompatibility. So, A positive blood group, A positive patient will receive a heart from A positive only, AB positive from AB positive only, O from O only. So, ABA compatibility is a must to overcome this hyperacute rejection, which happens on the day of surgery itself. HLA typing is though desirable, it is not practical in a heart patient. It can be, it is done in kidney transplants, but this heart transplant is not possible, because the time period when a patient is brain dead and then getting to this to the recipient hospital, you have got hardly a short window period, and that time you can't do all these things. But we do when we test them and we evaluate them for heart transplantation. We will be doing something like panel reactive antibodies to see whether he has got pre-formed antibodies. On the day of donation, we do a DSA to see whether there are any antigens, antibodies, and so cross match the donor and the recipient blood, and if everything is good, then hyperacute rejection is avoided. And subsequently, you can have an acute rejections that are cell-mediated rejection. Through lymphocytes, the heart is identified as a foreign organism, and then the lymphocytes kill. Or there are antibodies, the humoral rejections or microvascular rejections. So all these things are in the current era are taken care by immunosuppressive agents. So you have got induction therapy and the maintenance therapy, and they take those drugs for life. In spite of this, every heart recipient will experience at least one rejection.
Absolutely. In his entire lifetime.
Yes, one rejection he will take. Yeah, because you are suppressing the immunity of the person.
So, who are the ideal donors? Who can donate the heart?
Typically the donor is a road traffic accident victim. His brain is irreversibly damaged. A neurologist gives an opinion that his brain is dead.
Irreversibly dead.
Yes, and then it is recertified after 6 hours by another neurologist that yes, indeed it is gone. So then he becomes eligible for donation of the heart, provided his heart is normal. So he has to have a normal ECG. He has to have a normal echocardiogram. His enzyme levels should be normal.
Within normal limits.
Yeah. In a road traffic accident, say his heart should not have a contusion. He should not have other anomalies which precludes and especially more than 60 years of age, that donor, though the family consents for donation, we do not take those hearts. More than 40 years, we would definitely like to have a coronary angiogram to see whether there is any coronary artery disease, and if there is a coronary artery disease, we don't accept that. So by and large, when a donor is there for a donation, only about 30-35% of them they go actually for heart transplantation. For example, in Karnataka, until this date, there were 125 donations that happened, but only 30 hearts were used in Karnataka. So the rest of the heart will go for a homogram.
Like 1/4 only, 20?
Yes,
20 to
not
25%.
all.
Not all.
When he says the heart is available for donation, all the hearts do not go to a heart recipient.
Okay. So how are the donor hearts allocated? Like there should be some system at the national level or state level.
Yes.
How do we allocate and how do we prioritize and decide who is the one who is going to get the heart? And there may be multiple candidates, age-wise and like other disease-wise, prognosis-wise, life expectancy-wise. How do we allocate the hearts?
A potential recipient, which is decided by the cardiologist who are treating the end-stage heart disease, they do a series of tests to see whether his 1 year survival, the possibility of he surviving the next 1 year.
1 year.
Okay, and most of the time the test they do is the VO2 max. If it is less than 14 ml, oxygen consumption, they think that his 1 year survival is very, very bleak. So a end-stage heart failure, which is likely to the patient likely to be not alive at the end of 1 year. So they will do further investigations like whether he is suitable for a heart transplantation with various other tests which precludes a heart transplantation. For example, the patient has got say a diabetes, chronic diabetes with end organ failure. So they are not considered. Age more than 65 years.
Or other organ systems involved.
They are not considered. Having a malignancy, not considered. HIV status, if they are positive, not considered. And they do a CAT study also to see the transpulmonary gradient, PA pressure, higher values precludes a heart transplant. The new heart is unlikely to survive in the recipient. So once they decide that this patient is a suitable candidate for heart transplantation, they register that in a body called the state SOTO, state organ and tissue transplant organization. It is called Jiva Sarthakate in Karnataka, and they work along with the NOTO, that is a national organization. So they register their name there, and usually there is a transplantation coordinator in each hospital which has been licensed for heart transplantation. So it can happen only in the licensed centers only, which is the license is given by.
So ours is a licensed center.
We have got 17 licensed hospitals in Bangalore. About 6 or 7 are actually active, and so it is a very transparent way of doing things. And there are certain times the clinicians ask for a urgent allocation, so that also is taken into consideration. If the donation is happening in one hospital and if there is a recipient in that hospital, it goes to that hospital, so that chances of success is high. So it will not be given to another city, so it is.
So it is properly facilitated and coordinated, like in a very nice manner. So something about xenotransplantation. So we are short of human organs. Like, what is the concept of xenotransplantation? Is it a viable, feasible concept?
Xenotransplantation, everybody is talking, including you. After the Barclay Griffith did the xenotransplantation in January this year, the pigs. The pig is supposed to be genetically some 98% similar to human beings. Chimpanzees, genomes, and the chimpanzees are 98.6. They are similar to. But to tell you the truth, bananas resemble human beings genome-wise 56%. So phylogenetically, even if it is 98%, there is a vast difference. So they genetically modify the pig that is to be reared and put it in a different, so that they do not develop zoonotic diseases, and certain genes are knocked out, especially the growth hormone genes are knocked out, because the pigs grow very fast. They grow fast to about 400
They can outgrow humans, organs.
400 pounds, very fast. So the heart of the pig has been taken by the Dr. Griffith and put in a patient called David Bennett in January. That heart was working like a human heart for about 43 days, and subsequently patient had some problem. It is suspected that the patient, that porcine heart had pig cytomegalovirus, a dormant pig cytomegalovirus.
It got activated.
It acted against its own heart. The pig heart only, which has been implanted in the human being. So in the words of Dr. Barclay, you should be cautiously optimistic. Yes, it is required in those countries wherein the number of transplantation surgeries done each year is less than the number of people who are in the waiting list. For example, in Karnataka, the number of heart transplants has happened is 30 this year. The people who are in the waiting list is 56 now. But in our country, I feel the organ donation rate is less. It is about 0.5 per million. In the developed countries, about 50-60 per million donation happens.
0.5 per million is
about 100 times more. But in spite of that waiting list, in our country, I feel making it more, awareness among the public that a donation is possible. A brain dead, the relatives decide, whether to give the other organs or not. So once a brain dead patient is eligible for a donation, the grief counselor and the transplant coordinator talk to the patient's relatives, and it is a very difficult period, for the people to say yes also. But then they should be aware that instead of burying or burning those organs which are alive now,
it can be
used in around 8 to 9 patients.
Some other form of life.
Some life in some other people. But in some countries, the donor and the recipient, they know each other. But in our country, we totally want to avoid commercialization, so the donor's identity is not revealed to the recipient. It is nobody knows. We can see in WhatsApp some heart, the parents listening to the hearts of their, the donor's family listening to the heart in a recipient. That cannot happen in our country, because they are not revealed. The identity is not revealed. So in our country, I feel the more awareness, more donation, if it happens, we don't require this xenotransplantation thing. It is not needed in our country.
So from your demeanor, from your behavior, all of us know that you are very humble, you are very smiling and charming. And today I want to remind my viewers again that we are with Professor Dr. Seetharam Bhat, who has pioneered the heart transplantation program in Shri Jaydeva Institute of Cardiovascular Sciences. So a last word from you, sir. What is your message, and how do you see the domain of heart transplantation 10 years from now on? Like a message to the youth, like an inspiring message, and a message to general masses, how to take care of their heart, so that they cannot reach to such a level where heart transplantation is required.
Okay. Yeah, the prevention is better than cure. Many of the heart transplant recipients are patients of ischemic cardiomyopathy, and there are so many ways to prevent heart attacks. So we know we have knowledge of which causes the heart attacks.
Yes.
Okay. The smoking, tobacco usage in any form.
Risk factors.
Okay, risk factors. Try not to become obese. Don't eat junk food. Your body becomes junk. Okay. Regular exercise. Then good control of diabetes. Good control of hypertension. Hypertension and diabetes, it is the doctors who tell the patient that you have got a diabetes, you have got a hypertension. For them, they don't have any symptoms. Only when everything goes, then only they stroke.
Make them understand the gravity and seriousness of the disease.
Yes, so good control of diabetes. And lead a stress-free life, have good sleep, enjoy the profession. If you don't enjoy the profession, change the profession.
Some sort of mental relaxation like yoga, relaxation, music,
meditation, and pursuing your hobbies. Especially doctors like you, the cardiologists, don't be okay. Don't stress yourself too much. Have some time for family. Have some time for friends, colleagues. Okay, and take care of your heart.
Thanks a lot for attending and giving us your precious time. Thanks a lot.
Thank you.
Thank you.